I think sir joined. Welcome back, sir. Dr. Nursing.
Hello.
Could you hear me, sir?
Yes, I'm getting your voice.
Yes, sir. So now we will start, sir. And this will be the agenda. After welcome and introduction speech, it will followed by your presentation. And after your presentation, the floor will be open for the question answer session, and then vote of thanks from the Wockhardt.
Yes.
So we are starting now. Mr. Ravi, we are starting, sir.
Yes, yes.
Yeah.
So recording, I think we can start. My slides are visible to all, Mr. Ravi?
Yes.
Yeah. So, ladies and gentlemen, good morning from Dr. Amarjit Singh, a part of the medical team. So, welcome to all in another session of iTrust webinar. So, it is with great pleasure that we extend a warm welcome to Dr. Narsingh Verma, who is a distinguished speaker in our iTrust webinar, focusing on the critical care topic, that is managing hyperglycemia in hospital setting. Dr. Verma's presence here today is testament to our commitment to providing you the most valuable insights and expertise in healthcare. Very brief introduction about Dr. Verma, because he has a very long, it will take hours to explain his experience. However, in one slide, we have summarized. Sir, at present, sir is the professor in the Department of Physiology in King George's Medical College. Past, sir was the former medical superintendent at GM and Associated Hospital, KGMU Lucknow. Sir has done his MBBS from KG Medical College Lucknow and MD from KG Medical College Lucknow. Sir has a huge number of publications, so that is, you can see the number 150, that is 150, and sir has several abstracts also. And sir has life membership of some international bodies like International Society of Heart Research, International Society of Hypertension, and American Diabetes Association. So this is very brief introduction of Dr. Narsingh Verma, because I had seen Sir CV, it's a very big one. So without taking much of time of our attendees and faculty members, I will request Dr. Verma to start his presentation. So the floor is yours, sir. If you can share your slides, sir, I will just stop sharing.
Yeah, definitely. I'm going to share.
Yes, sir. So I'm just stop sharing.
If you want to, if you have already shared, no issue. I can talk with your slides. No issue. You can keep on changing.
This is the first slide, sir.
Okay. So this is the first slide now.
Yes, sir.
So thank you very much for giving this opportunity. And the topic is very exciting. The using the insulin and managing the glycemia in the ICU setup or the inpatients who are admitted there. So hyperglycemia and mortality, if you say, is seen non-critical care, then it will, you see that the patient with normoglycemia and patient with known diabetes and newly discovered hyperglycemia, it is shown here. Hyperglycemia is generally associated with increased risk of mortality. So whenever there is hyperglycemia, mortality will definitely rise. So we have to manage hyperglycemia, and it has also been seen that in ICU setup or in emergency setup, those patients who were not diabetic but having little bit hyperglycemia, they were also having the high mortality. So glycemia per se has an association with mortality. Next slide, please.
Yes, sir.
So it is already related to that. And here, if you see association between the glycemic variability, and mortality, And if you see here, the BMIs have been shown, the sex and race have been shown, the age has been shown, and the significant difference, what you can make it out, that with the BMI, there is a difference in the mortality. If you see the 90 days mortality and change in LOS, you will find that changes are there. But increased glycemic variability during hospitalization is independently associated with a longer stay in the hospital and also increased mortality in non-critically ill patients as well. So those who are having more glycemic variability, the change in blood sugar level within 24 hours and during the stay of hospital, if it is more, the amplitude is more, then definitely the outcome is not good. Next one, please.
Yes, sir.
Managing hyperglycemia in hospital setting, that is the topic of the day. And here, the anti-hyperglycemic therapies which are used basically, definitely insulin is the top on that, and the OADs are not generally recommended, because in hospital setup, when patients are in the hospital, then insulin the better choice, because we have to reduce glycemic variability. And there are other parameters as well, because insulin has some very basic the indications which are compelling indication where the only insulin can be used, and in that compelling indication, our primary indication, hospitalization is one of the major indication, because here insulin is the best treatment available, and treatment should be given to most of the patients. Why? Because these patients are having inflammation, they have infection, and most of the time these two, when they are there, and they are metabolically unstable. So because of these three factors, insulin becomes a drug of choice, not the oral anti-diabetic drugs. And when we say that insulin is the drug of choice, then it can be used either subcutaneous insulin or intravenous insulin. And we all know better that intravenous insulin is preferred in critically ill patients while they are in intensive care unit, while subcutaneous insulin can be given those patients which are hospitalized, but they are not very critical, and here the subcutaneous insulin can be given. And you can very well understand that intravenous insulin starts working at the same time it is given, while subcutaneous insulin takes time, and the action is also for more time. Next one. What the recommendations are? If we talk about recommendations, then see that the ADA recommends the targets. The targets are very important. And here we have the recommendations from ADA and from RSSDI. The targets are threshold for starting insulin when the glycemia, hyperglycemia is there and blood sugar levels are more than 180 milligram per deciliter. Target glucose range, what the range we are targeting should be between 140-80. That is the best. If the blood sugar level is below 140, it has been seen that the outcomes are not better. And if it is more than 180, again, the outcomes get worse. So the target of 110 to 140 milligram per deciliter may be appropriate only for selected patients if this can be achieved without significant hypoglycemia. If anybody can have this value and without significant hypoglycemia, then of course it is better. But most of the time, when we are trying to achieve this target, hypoglycemia sets in. Higher glucose ranges may be acceptable in terminally ill patients, severe comorbidities when they are having multiple comorbidities, or when close nursing supervision is not visible, our staff is not so trained, and they are not able to supervise it for more accurate time. RSSDI recommends the target same, ICU for same, and for non-ICU, fasting 80 to 120, pre-meal less than 40, and post-meal less than 40. I think they are saying almost same thing in a different language. Next one, please. And here, the targets have been defined. Now, the anti-hyperglycemic treatment in hospitalized patient, what are recommendations? Poor oral intake, our patient is having poor oral intake or nothing taking orally, then the basal or basal plus correction of insulin can be started. And when the patient is having good nutritional intake, then basal, pharyngeal, and correction components are taken in account, and sliding scale insulin is strongly discouraged. This is the old method which is no longer being practiced. Next one. Now, this slide compares the basal bolus versus sliding scale insulin. And here you see the basal bolus and sliding scale. And see here the results. And if you see the result, blood glucose levels, their management, the changes in blood glucose concentration in patients treated with basal bolus regimen are better controlled than the sliding scale. So if you compare both of them and see the target glycemia achieved and other components taken in account, the basal bolus insulin regimen is preferred over the sliding scale in the management of non-critically ill hospitalized patient with type 2 diabetes patient. Next one, please. Insulin regimens for managing hyperglycemia in non-critically setting patient. Here the non-physiological with retrospective reaction to blood glucose levels. They lead to poor glycemic control and increased risk of hypoglycemia, and they lead to promote glucose roller coaster and cannot predict insulin doses requirements. So not individualized, so reactive approach practice. So this is not good. We cannot have the reactive approach practice. Roller coaster effect of insulin sliding scale, which is shown here. When insulin is given and no insulin is given, either patient is in hyperglycemia or in hypoglycemia. So this is no longer practiced, no longer advised. Next one, please. The basal bolus regimen, definitely superior efficacy compared to SSI. And here the physiological way of glycemic control is there, and it addresses three components: the basal fasting state insulin requirement, which is most of the time almost in a healthy individual, it is 50%. 50% requirement is met only by the fasting state basal one. And bolus, it depends upon the meal time, it depends upon the meal size, but the meal time insulin requirement and correctional unexpected glucose elevations are disposed of elevated hyperglycemia. Whenever we find hyperglycemia, then correctional doses can be given, but the basal bolus are the part and parcel of it. ADA recommends use of the basal bolus regimen in inpatient settings, and implementing basal bolus therapy in non-critically ill patient will improve glycemic control with fewer hyperglycemia and hypoglycemia episodes. So no roller coaster effect. Next one, please. Hyperglycemia treatment for hospitalized patients eating a normal diet. Those who are taking a normal diet, but they are hospitalized due to some reason, and because of monitoring, they are in the hospital, they are being given intravenous antibiotics or some other regions, intravenous fluid. So in these patients who are taking normal diet orally, critical care settings, the hospitalized patient with diabetes or new hyperglycemia on a general medical surgical ward who is expected to eat a normal diet, type 1 or type 2. They will differ in type 1, insulin-treated type 2 diabetes patients are significant and sustained new hyperglycemia. Here, the continuous outpatient insulin regimen, if glucose is well controlled, consider modest 25 to 50% dose reduction, since nutritional intake likely to be more restrictive as inpatient, which is very important. And then in type 2 diabetes patient not treated with insulin, On diet only, oral agents are GLP-1 agonist. Here, continue outpatient regimen if glucose well controlled and no contraindication are present. Be particularly cautious with metformin, and most of the time it had to be stopped. Consider modest dose reduction of any secretagogue sulfonylurea, since nutritional intake likely to be more restrictive as inpatient, because now the medications and other things will follow, and patient had to go into restrictive state. Next one. Here you see if blood glucose poorly controlled, and then begin basal insulin. The control is not good, begin basal insulin, advance from home dose, or start with 0.2 to 0.3 unit per kg per day. This is the dose where we can start. Suppose patient is 50 kg, then you can start with 10 units. And similarly, it can be started with 15 units. And pH every 12 hours, detamel every 12 to 24 hours, or glargine every 24 hours. In my practice, I do not prefer NPH, but the glargine is the preferred choice most of the time because it has got 24-hour effect. But these all three had been recommended. Prandial insulin, advance from home dose, or start with 0.05 to 0.1 unit per kg per meal, 0.5 to 0.1 unit, 0.05 to 0.1 unit per kg per meal. Insulin, Lispro, Aspart, Glucine, or regular insulin, any of them can be given. We know better that these ultra short-acting insulins are better control, and the high chance of hypoglycemia are further reduced, but even regular insulin can be given. The correction insulin for blood glucose more than 150. After basal bolus, start basal bolus therapy. If even in between, you find that the blood glucose level is crossing 150, then the correction insulin doses had to be given. And in here, the 8.3 millimole per liter or more than 150 milligram per deciliter is better term. And here the graded scale of 1 to 4 units for each increment of 50 milligram per deciliter. So 1 to 4 units for each increment of 50 milligram per deciliter. So here 150, we can give 2 units or 4 units. Based on suspected insulin sensitivity, same type of insulin as prandial insulin above, and a blood glucose level not controlled, make the following changes, taking into the consideration other factors that might be responsible for hyperglycemia. And what are these factors? They can be because of the adjustment required in basal insulin dose by approximately 10 to 20% every 2-3 days to achieve glucose target, and adjust prandial insulin scale by 1 to 2 units per dose every 1 to 2 days if response is inadequate, and adjust correction insulin scale by 1 to 2 units per dose every 1 to 2 days. It should not be in very hurry, 1 to 2 units in every 1 to 2 days. Next one, please. So here the hyperglycemia treatment for hospitalized patient receiving nothing by mouth. They are not taking anything in the mouth. And in these patients, if they are type 1, then we have to start basal insulin plus the corrected insulin for blood glucose more than 150 and regular insulin every 6 hours. So this is the regimen. And type 2 diabetes, discontinue all outpatient anti-hyperglycemic agents. This is very, very important. And begin correction insulin for blood glucose more than 150 and regular insulin every 6 hours. So nil per or nothing by mouth, this condition here, we can use this particular methodology. Next one, please. Here, if the blood glucose level is not controlled, then adjust basal insulin dose by approximately 10 to 20% every 2-3 days to reach target. Until you get target, increment in doses will continue, and adjusting the correction insulin scale by 1 to 2 units per dose every 1 to 2 days if response adequate. See here that prandial insulin is not required because here the patient is not taking anything orally. So adjusted correction insulin scale is required. And consider intravenous insulin infusion if control is not good in type 1. In type 2 diabetic patients, those who are having uncontrolled, then you go for adding the basal insulin and the every 12 hours, the basal insulin doses can be corrected and adjusting the correction insulin scale by 1 to 2 units per dose. So very simplified methods, they can be utilized, they can be used, and very simply we can control blood sugar level in the hospitalized patient. Next one, please. Dosing basal bolus in non-critical care. The steps are calculate total daily dose, divide total daily dose equally between basal and bolus 50%. I said in the beginning, 50% basal is enough, and both bolus insulin is divided equally in between 3 major meals. 3 major meals. So 50% bolus, 50% basal, and bolus divided into 3 major meals. Measure blood glucose 4 times a day, 4 times a day, 3 pre-meals and 1 at bedtime. Measure insulin sensitivity, and based on blood glucose measurement and insulin sensitivity, add correctional insulin to bolus. Based on fasting prandial glucose, titrate basal. Again, very, very simple method. And how to titrate it, the patient characteristics will define, and how to start with 0.4 to 0.5 unit per kg when the patient is the ideal weight, and 0.5 to 0.6 unit per kg when patient is obese, and 0.3 to 0.4 unit per kg in the lean and renally compromised patients. Next one, please. So the correctional insulin protocol again shown here. If the blood glucose is between 100 to 140, no change is required. And when the 141 to 180, 2 unit insulin increment to be given in insulin sensitive patients, and 4 unit in usually most of the patients, and 6 unit in insulin resistant patients. And with between 181 to 220, this insulin sensitive patient, 4 unit usual portion, 6 unit and 8 units in insulin resistant patient. And as the blood glucose level rises, you see that more insulin is required, and the chart is given here. So this gives us idea how we can control hyperglycemia in ICU settings. Next one, please. So basal bolus regimen is ease of titration, very easy to titrate, effective glycemic control, and the lower risk of hypoglycemia, which is our aim, and flexible and simple dosing and simple methodology uses in wide range of population. Right? Next one, please. Factors that influence blood glucose control in insulin-treated hospitalized patients with diabetes. The factors that increase the risk of hyperglycemia must be kept in mind, and they are the patient characteristics like high insulin resistance, previous poor glycemic control. These 2 factors are very, very important, and factors that increase the risk of hypoglycemia like advancing age and chronic kidney disease, very, very common, compromised kidney, congestive heart failure, again because of the circulatory failure, this can happen, and duration of diabetes and insulin therapy. These patients do not respond well, and food malabsorption like gastroenteritis or celiac disease. Liver disease, malignancies, malnutrition, prior episodes of hypoglycemia, renal failure, type 1 diabetes. Next one, please. And factor that influence blood control, insulin-treated hospitalized patient with diabetes. Here, the clinical status and therapeutic choices are responsible for the factor that increase the risk of hyperglycemia, like critical illness, decreased activity levels, persistent bed rest, and internal or parenteral nutrition, internal and parenteral nutrition, or increased appetite, recent end of nil per or OS status, these patients require more, and release of the stress hormones, sudden initiation or dose increase of concomitant corticosteroids. This is again very, very common situation, and is like the patients of COVID and other similar patients, we require doses of the corticosteroids, and here the insulin requirement will definitely going to vary. Factors that increase the risk of hypoglycemia, they are the general anesthetic or sedation, infection, new nil per OS status, reduced or unpredictable appetite, renal failure, sepsis, shock, sudden termination or dose reduction of corticosteroid therapy, and trauma. So these are the situations where the factor they can produce hypoglycemia. We should be aware of their conditions. Next one, please. Factor that influence blood glucose control in insulin-treated hospitalized patient with diabetes. Insulin-treated, here the diabetes management, like the factor that increase the risk of hyperglycemia, they are the excessive insulin dose adjustment at admission, failure to adjust insulin dosing with changing clinical status, and inadequate or no blood glucose monitoring. That is one reason. And insulin dispensing error, very, very common, because that requires a lot of education. Interruption to blood glucose monitoring routine, transportation of the ward, and overfeeding outside carbohydrate-rich food brought into hospital for the patient. And also sometimes the insulin is not working because it is a poor quality, or the improper handling has destroyed the insulin. That should also be kept in mind. And factor that increase the risk of hypoglycemia, failure to adjust insulin dosing with changing clinical status, inadequate insulin dose adjustment at admission, inadequate low BG monitoring, insulin dispensing error, and interruption to BG monitoring routine, and the mismatch between nutritional insulin administration and food delivery. So these are some factors which can lead to hypoglycemia. Next one, please. The avoidance of hypoglycemia is must, and this can be achieved by hypoglycemia should be avoided if at all possible, and adequate reduction in anti-hyperglycemic therapy. When caloric intake is stopped or reduced, we have to be very, very careful, and avoidance of standard sliding scale. This is very, very important. This should not be done, and the avoidance of overly aggressive attempt to provide tight glycemic control or very tight glycemic control, which is not warranted. Next one, please. Monitoring is very important at admission before an OPD procedure or treatment, and continued so that apparatus, the appropriate action can be taken. At time and frequency of monitoring depends upon the patient status, the result of the earlier measurement, steps taken at the result of these management. And if patient with diabetes or hyperglycemia who are eating, then monitoring should occur just before the meal, because that is more important. And in those who are NPO or continuous tube feeding or TPN, here the monitoring should occur at regular fixed intervals, because their meal is in different way. Usually every 6 hours will be enough. And mode of monitoring should be definitely conventional capillary glucose testing by the finger stick and glucometer. That is the best way. We don't have any better way at present. The CGM is not generally recommended for the inpatient or critical care settings. CGM has been used in inpatient more frequently since COVID-19 patients. Next one, please. Goals of the hospital setting: avoid hypoglycemia, avoid severe hyperglycemia, volume depletion, and electrolyte losses. Ensure adequate nutrition, assess patient education and needs, and address informational deficiencies. ensure appropriate glucose management upon discharge until patient can be seen by the clinician managing his or her diabetes as an outpatient. The main goal in patients with diabetes needing hospitalization are to minimize disruption of metabolic state, prevent adverse glycemic event, and return to a patient to a stable glycemic balance as quickly as possible and ensure a smooth transition to outpatient case. And now the patient will like to have the treatment as before admission he was taking. Next one, please. So that is the what I wanted to present. Thank you very much. And now it is the time for the discussion, what we can have.
Thank you, sir, your dynamic presentation. So the floor is open now. So we welcome questions from our attendee. So Dr. Verma is here. Take the benefit of sir, and you can ask the topic related questions. Sir, we cannot find any questions till now, or neither raise hand. I think they are very crystal clear
I
with the
think
sir
it was very
presentation.
simple and nothing new was there. So the questions are not coming because this is known to everybody. I was not talking something very different. And if talk something different, then the question definitely arise. And we all know that sliding scale is gone. We are using this method of the basal bolus, and definitely what I usually do, and in those patients, even those who are not hospitalized, because hospitalization in India is different. In Western countries, hospitalization or no hospitalization is governed by so many authorities, especially the agencies which provide the them treatment cost or insurance companies. But in India, most of the time, the expense from their own pocket. So hospitalization is not that frequent in my country. Sometimes even patient, those who are taking orally, we do not admit them and we keep them at home and they can come to us morning, evening and giving their report. So that is why we are different in relation to other countries. Thank you.
However, sir, this is an opportunity for our attendee to ask if they have any query topic related. May not be topic, but maybe with insulin use. I think, but your topic is crystal clear, sir. So now I will request our Mr. Ravi for the vote of thanks. Yeah, Mr. Ravi, over to you.
Yeah, thank you, sir. Thanks. First, before going to vote of thanks, I would like to share one great news with all of you that we have Wosulin, and Wosulin has completed 20 years, successful 20 years. 2003, we launched Wosulin and put India on the global map. India became the third country and who started producing its own indigenous manufacturing of insulins. And after coming to this vote of thanks, first of all, I would like to thank Dr. Narsingh Verma for taking his time and accepting our invitation and for being a speaker for this webinar. Thank you, sir. Thanks a lot. And special thanks goes to our IBB head and our AVP, our IBB head, Mr. Amrut Medekar, sir, and our AVP, Mr. LCS Vishnu, sir, for their continuous guidance and support for conducting these webinars every Saturday. And after this, I would like to thank all our medical team, Dr. Kunal, Dr. Sanket, Dr. Amarjit Singh, for their continuous guidance and medical inputs and such a good coordination with the doctor and this entire webinar. And after this, lastly, I would like to thank all our HO colleagues and our field colleagues who, working hard for the for this webinar to make it successful. And once again, I thank all the delegates who are present here, who took their time and joined this webinar on the Saturday. And thank you, sir. Thanks again, Dr. Narsingh Verma, sir. So we
Thank
are
you, sir.
signing off now, and stay tuned. We'll come back soon on next Saturday. Thank you, sir.
Thank you. Thank you.